Good morning. Happy Monday. Welcome back. It's true fall outside with some rain, so that's welcome to Minnesota. Um, Wanted to first acknowledge also the exhibits outside. We have MGN and Edwards Life Sciences that have been graciously supporting also this initiative with the grand rounds and also Maya for coordinating. Today we have our own special Dr. Clerio Azevedo, who is originally also from Brazil. He trained at the Universidade Federal de Rio de Janeiro in Rio in 1998. He completed also medical school residency and fellowship. And then he's decided to then go to Johns Hopkins in Baltimore and spend a couple of years with another fun friend, colleague, and also a mentor to me indirectly, Dr. João Lima, who led MESA study. And Clerio really did a lot of very important work and some translational work in using cardiac MRI, myocardial infarction, and developed his passion focus on both cardiac MRI and then CT. He returned to Brazil. He did his PhD Universidade de São Paulo, did his PhD there in INCOR, the largest institution in cardiology, and then went back to Rio to then assume and probably one of the largest private imaging group practices in which he did a lot of cardiac CT and MRI. Not satisfied with so many moves, he decided to move back to the United States, or come to the United States again. He went to Duke University, where he was part of the Duke Cardiovascular Magnetic Resonance Center under Dr. Raymond Kim. He started as an assistant professor and spent 6 years there. We were fortunate to actually recruit him. He joined us here in this past April of this year, and it's really fun to have another colleague that also has a very astute intellectual and emotional intelligence as well. He's going to be talking to us about the role that cardiac MRI has for hypertrophic cardiomyopathy, and I thought this was going to be very apropos for this institution that has had a legacy with Dr. Barry Mann and John Lasser and many others. We'll be looking forward to this talk, and then we'll take questions at the end. Clerio, bem-vindo, welcome.
Thank you. Thank you, João, for the kind introduction. Good morning, everyone, and I would like also to thank the Minneapolis Heart Institute Foundation for the opportunity to give this presentation. So I'll be talking about, as João mentioned, the role of cardiac MRI in hypertrophic cardiomyopathy. I'll discuss the current practice and then address a little bit of the future perspectives. So I'll just start with a very short background. So hypertrophic cardiomyopathy is the most common genetic cardiomyopathy, with as many as 1 in 500 individuals in the general population being affected. It's the most common cause of sudden cardiac death in the young. More than 1,400 known mutations in at least 11 genes, including proteins of the cardiac sarcomere. And it's a very heterogeneous, it has a very heterogeneous phenotypic expression with a very diverse natural history. And I think this is why I think one of the reasons cardiac MRI can help a lot, because it can help characterize all the spectrum of the disease. So what is the role of cardiac MRI in assessing patients with hypertrophic cardiomyopathy? So first of all, I think it helps with diagnosis. As we'll discuss, echocardiography is the first line technique to diagnose these patients. But more and more, I think cardiac MRI can contribute, and I think it's becoming an essential component to complement echocardiography data. And it also, I think it's very important with phenotypic characterizations. We will see there are a lot of features that cardiac MRI can help characterize and that are very important in terms of decision management decisions. It may help also with screening of family members, and we'll discuss some details about that. Also very useful for differential diagnosis. Sometimes it's difficult to differentiate hypertrophic cardiomyopathies from other disease that can mimic the phenotypic expression of hypertrophic cardiomyopathy. And it's also, I think it's becoming crucial as one of the tools for risk stratification of these patients for sudden cardiac death. And as I said, it helps throughout all this process with management decisions. So starting with diagnosis, as I mentioned, the echocardiography is the first line technique. And the definition of hypertrophic cardiomyopathy, I think this is well known. It's just to start this discussion. It would be the unexplained LV hypertrophy, 15 millimeters or more in wall thickness, in the absence of another disease capable of producing this magnitude of wall thickness. So, and the question, I think, is echocardiography enough? Is it, does MRI has anything to offer in terms of diagnosis? And I think this is one of the earlier studies that showed that actually it does help, because echocardiography, due to a number of limitations, may not identify hypertrophy in as many as 6% of patients with hypertrophic cardiomyopathy. And in this study, it underestimated the severity of hypertrophy in 10% of patients. This study focused especially in patients with apical HCM, and it showed that also, particularly for apical HCM, the echo can miss the diagnosis. In this patient, they studied only 10 patients, but showed that in all these patients, the echo was normal, but MRI was able to detect hypertrophy as severe as 2.8 centimeters. There are some areas of some walls of the left ventricle that are particularly blind to or difficult to image by echo, and that would be the infraseptal wall, in this example, as I mentioned, the LV apex, and the anterolateral wall as well. This study here, done here by Dr. Lesser, Dr. Maron, and colleagues, showed the same pattern, that the echo may underestimate as much as 14 millimeters in terms of wall thickness when compared to CMR. And more recently, I think this also trying to address this same issue. And this study showed that as many as almost 93% of patients, the echo underestimated or overestimated maximal wall thickness. Underestimation was mainly because of focal LVH, or poor acoustic windows, and it overestimated mainly due to inclusion of RV myocardium, LV trabeculations, papillary muscle, as well as imaging obliquity. And importantly, in as many as 16% of patients, this measurement discrepancy resulted in diagnostic or prognostic cutoff changes. So it would change like the diagnosis of the patient or prognostic assessment because of this discrepancy in measurement. But MRI can not only help with the diagnosis of the disease, but also with phenotypic characterization. And I think this is one of the main features of MRI. So, and what do I mean by that? So MRI could help characterize the patterns of left ventricular hypertrophy by looking at the distribution of hypertrophy, measuring maximal wall thickness, also looking into the presence of RV hypertrophy, apical aneurysm, and we'll discuss the importance of that. Also very important in those patients with LVOT obstruction, the MRI can help determine, or try to help determine, the mechanism causing the obstruction and what are the main factors driving this, so that when we look into what to do in terms of management, I think this is very important. So MRI can look at the SAM, systolic anterior motion of the mitral valve, can measure elongated anterior mitral valve leaflets, papillary muscle abnormal position insertion, a small left ventricular cavity with basal septal hypertrophy, and we'll see examples of those. Mitral regurgitation secondary to SAM, and also in some patients may also help quantify LVOT obstruction severity. And also, in terms of small vessel ischemia, we know that this is a feature in patients with hypertrophic cardiomyopathy, and with stress perfusion MRI, we can also try to assess that, as we'll see. So starting with the patterns of this distribution, so this is an interesting study based on the HCM registry, and they describe this different categories or different patterns of distribution. So here we have the basal septal hypertrophy. This is one of the most common one. It's more kind of a isolated basal septal hypertrophy. We have the reverse septal curvature. pattern, also very common, apical HCM. We have the concentric pattern. We have the mid-cavity pattern hypertrophy with an apical aneurysm. And this would, like other patterns that do not fit any of the previous ones, would be a hypertrophy of the lateral wall. We have some images of our own showing here this different patterns. So the isolated basal septal hypertrophy, the reverse curvature, concentric hypertrophy, apical HCM. Here we have isolated of the hypertrophy of the infraseptal wall, mid-cavity hypertrophy with the aneurysm, again septal hypertrophy, and this would be more pronounced hypertrophy of the lateral wall. So with MRI, I think without any limitation in terms of acoustic windows, I think it's very easy for us to image the left ventricle as a whole and to try to determine what the pattern is. Very important is trying to determine the maximal wall thickness because this has impact in management decisions. And then we have to be careful with the crista supraventricularis. So this is something that we see a lot that tends to lead to overestimation because we should not include, as we measure the maximal wall thickness, we should not include the crista supraventricularis. So this is the crista that runs through the right ventricle and inserts here in the basal septum. So we see here the crista as it inserts here in the wall, and we should not measure here, including the crista. So I would, for example, measure either here or here, but we have to avoid this. We have another example showing again. Here's the crista inserting here. Here in the wall, and then we see the crista here. We should not include it in the measure, otherwise we will overestimate. Right ventricular hypertrophy, some of these patients have not only left, but also right ventricular hypertrophy. We have here 3 examples showing here right ventricular hypertrophy. This patient even more pronounced. We see even some flow acceleration here in the cavity of the left ventricle, so a mid-cavity flow acceleration here in the RV. And this is another example here of RV hypertrophy. Very important, apical aneurysm. So here we have an example. HCM involved the septum, but also lateral wall. And then we see this area, clear area of apical aneurysm. And using the delayed enhancement technique, we can also characterize this and show that actually this is an area of transmural scar, even simulating what could be a distal LAD infarct, but this, in the context of HCM, this is consistent with an apical aneurysm in a patient with hypertrophic cardiomyopathy. I have 2 more examples. So here we can see again mid-cavity, and then this apical aneurysm, even with a little bit of a thrombus here at the apex. And we can see here the aneurysm. And another example, again, showing this mid-cavity hypertrophy with an apical aneurysm. And this has important prognostic implications, as we'll see. Very important also to define and try to quantify LVOT obstruction. So as many as 70% of patients have the propensity to develop LVOT obstruction with dynamic gradients of 30 millimeters of mercury or more, either at rest or with provocation. And this is actually the most relevant clinical determinant of HCM-related progression to heart failure. So as we can see here, if the patient has the non-obstructive HCM, most patients will not have significant heart failure symptoms. So here, only 10% will have like New York Heart Association class 3 and 4 symptoms if it's non-obstructive. If it's obstruction only with provocation, then it increases a little bit the chances of going into significant heart failure. And if the patient has obstruction, LVOT obstruction of rest, then the chance of having heart failure at some point increases significantly. And here it's also important to note that the prognosis of patients with obstruction is worse. So if they have obstruction, then the chances that they will have an adverse event is higher. But if we do treat that, for example, with myectomy, then we can see that the prognosis of the patients then reverts back to the baseline expected events of the US population. So addressing this LVOT obstruction can change the prognosis of this patient. So it's really important to not only identify this, but also understand what's causing it. So it's, and LVO obstruction is mostly driven by the systolic anterior motion of the mitral valve leaflets, and then contacting the ventricular septum in mid-diastole. So we'll see images of that. And there are some morphological alterations in the LVOT area that can lead to this SAM septal contact. And those would be a narrowed diameter of the LVOT. So if the LVOT is narrow, if it's small, then the chances of SAM happening increases. Apically displaced papillary muscles, it can tether the mitral valve leaflets towards the septum and then increase the chance that this will happen. And also elongated anterior leaflet, so the leaflet is just too long, and then also this excess redundant leaflet can touch the septum and cause SAM. Interestingly, and we'll see some examples, systolic anterior motion of the mitral valve can also be associated with mitral regurgitation, mostly posteriorly directed jets. So here we have an example of systolic anterior motion of the mitral valve. So we can see here the anterior leaflet, and we can see here during systole, there's this motion. Oh, I'm sorry. There is this motion of the leaflet towards the septum. We can see here, again, the leaflet motioning and almost touching the septum, and the flow acceleration during systole. Another example, we can see here this elongated leaflet, kind of redundant, and then moving towards the septum and causing this flow acceleration. Another example with the elongated mitral valve leaflet, and then this SAM with the leaflet moving towards the septum and obstructing the LVOT. So as I mentioned, a papillary muscle abnormal position, if it's apically displaced, can also contribute to this. And here we have this example showing this papillary muscle, and we can see that it inserts here very close to the LVOT tract, LVOT, and also this intraventricular band here also inserting here close to the LVOT. Another example showing this left ventricular band here also running in the direction of the LVOT, and here we can see the papillary muscle also inserting very close to the LVOT area. I think we have another example. Again, we can see here the papillary muscle apically displaced. You see it's almost attaching to the apex of the left ventricle and going towards the LVOT area here, contributing to the obstruction. If the cavity is too small also and the LVOT it's narrow, then it makes very easy for the obstruction to occur. So we can see here a very narrow left ventricular cavity, and then a very narrow LVOT as well, and then a lot of flow acceleration and a little bit of MR here as well. So if it's narrow and the cavity is small, then it's easier to have the obstruction. And as I mentioned, we can have secondary mitral regurgitation to SAM. So the systolic anterior motion displaces the leaflet and then causes this mitral regurgitation jet that, as I mentioned, it's most frequently posteriorly directed, as in this example, but sometimes it can be central or even anteriorly directed. But mostly, in most cases, it's posteriorly directed. So another example of mitral regurgitation caused by SAM. We can see here the jet. And then, as I mentioned, we can try to quantify the degree of LVOT obstruction. We would have to have a lot of planning in terms of getting perpendicular to the jet. So we have to image the LVOT area and the jet using multiple long axes, sometimes doing even this in-plane phase contrast image. This is similar to Doppler echocardiography, measuring velocities by MRI, so that we can see the jet and then try to be perpendicular to it and then measure the peak velocity with a graph like this. However, it's normally very difficult to measure LV severity by MRI due to a number of technical reasons. So I still think that for this, I think echo is it's the main technique to measure LVOT obstruction. It's possible to be done by MRI. In some cases, we try to do it, but I think echo is number one. One of the reasons is because when we measure velocity with MRI, in general, it's not a real time velocity. It's an average of several beats. And this kind of obstruction is a dynamic obstruction. So it would be very hard for us to, for example, try to measure velocity with provocation and so on. So technically, it's very challenging, but it's possible to be done. And as I mentioned, still with the phenotypic characterization, there's a small vessel ischemia. So these patients, the majority of these patients will have some degree of ischemia. We can see here the top row would be the stress perfusion. Then this row here, the middle row, is the rest perfusion, and the bottom row is the delayed enhancement. And we can see when we compare the stress with the rest, we can see this hypoperfused dark area, circumferential or around, involving all walls, all the way to the base, showing significant small vessel ischemia by MRI, and without a lot of fibrosis. And this we can characterize with MRI. And I believe, and we'll discuss that when we discuss prognosis as well, but I believe that this is an area that I think that would be very interesting to do research about this, because I think this may be a precursor to developing fibrosis, at least one of the factors that actually leads these patients to develop fibrosis and eventually being at a higher risk of sudden cardiac death. So screening of family members, so when to do it. So it's recommended that family members, if they are children or adolescents of genotype positive families, and especially if they have early onset disease, then they recommend checking for HCM when it's first diagnosed in a family member and repeating every 1 or 2 years. For all other children and adolescents, checking for HCM at any time after it is diagnosed in a family member, but no later than puberty, and then repeating every 2 to 3 years. And for adults, it's reasonable to check for HCM once it's diagnosed in a family member and repeating every 3 to 5 years. And this is mostly done by echo, but if the echo has any limitations, cannot get fairly good images, I think it's reasonable to include, at least in some of these assessments, an assessment by MRI as well. It's important to point out that in patients, when we're talking about family members, if the patient has increased wall thickness of more than 13 millimeters, it would be sufficient for diagnosis of HCM if this individual has a relative with diagnosed with HCM, or if they are genotype positive. So in those patients that are genotype positive, let's say they have a wall thickness of maximum wall thickness of 13 millimeters or 14 millimeters, that would be enough for the diagnosis of HCM. It doesn't need to be 15 millimeters. And also interesting is that some of these patients with genotype positive but phenotype negative HCM, we still see some features that we see that can be associated with this HCM genetic substrate. So, and those would be the presence of myocardial crypts, as I mentioned, the elongated mitral valve leaflets, and sometimes even delayed enhancement. So for example, here we have some examples of patients that do not meet criteria for HCM, but they are genotype positive. And we see here a crypt in the inferior wall, here a crypt in the septum, another crypt here, here a couple of crypts, and here we have several crypts here in the inferior wall. So this is something we may see. And as I said, for example, even the late enhancement. So this patient is genotype positive, but phenotype negative. But we can see here he has a tiny area of hyperenhancement or fibrosis here in the inferior septal wall. And this may also demonstrate possible early involvement, even though it does not meet criteria for diagnosis. In terms of differential diagnosis, so the differential with athlete's heart, this has been discussed a lot in the past. And I think it is a significant issue, especially in patients with this ambiguous gray zone of overlap between the two conditions when the maximal wall thickness is between 13 and 15 millimeters. If it's more than 15 millimeters, in general, it's not athlete's heart. It's very unusual that an athlete's heart would lead to wall thickness of 16 or more. This is very rare, so if that's the case, we tend to think that it's a hypertrophic cardiomyopathy. There are other features that help differentiate. So if it's a focal pattern, it would favor HCM. If the cavity is small, let's say the left ventricular cavity is less than 45 millimeters, then would favor HCM. If the cavity is more larger, it would favor athlete's heart. Left atrial enlargement, it says here favoring HCM, but in practice, it also can help in athlete's heart. So I wouldn't rely on left atrial enlargement too much. Strange ECG patterns can happen on both. Abnormal, so diastolic dysfunction, abnormal LV filling. So if there's diastolic dysfunction, it favors hypertrophic cardiomyopathy. Of course, a family history of HCM would favor HCM. Decreased LV thickness with deconditioning, that means what? That would mean regression of hypertrophy after deconditioning with a decrease of 2 millimeters or more in terms of wall thickness after 4 to 6 weeks of deconditioning. So of course, if that happens, that it would strongly favor athlete's heart. If the patient has a good VO2, then a functional capacity would favor athlete's heart. The presence of gadolinium enhancement and of course a mutation would favor HCM. Differentiation between hypertensive cardiomyopathy and hypertrophic cardiomyopathy can be difficult in some patients. So the first question is this: is the severity of hypertension consistent with the degree of hypertrophy? Sometimes I see this question and the patient has a hypertrophy, maximal wall thickness, a concentric pattern, but of 1.7. And when you see the patient is taking just 1 or 2 antihypertensive drugs at a small dose, so it would not be enough to cause this degree of hypertrophy, then it would favor hypertrophic cardiomyopathy, but some patients it's difficult because they may have resistant hypertension, then it becomes more difficult. A concentric pattern would favor hypertensive cardiomyopathy, but it can also occur, as we saw, with hypertrophic cardiomyopathy. The presence of LVOT obstruction and SAM, and especially if the patient has more extensive delayed enhancement, would favor hypertrophic cardiomyopathy. And of course, if there's regression of hypertrophy with treatment for hypertension, it would, of course, favors hypertensive cardiomyopathy. So here we have an example of a patient with hypertensive cardiomyopathy. We can see that the wall can become fairly thick, but we don't see a lot of delayed enhancement. It actually doesn't have delayed enhancement. And we can see here that it's a concentric pattern. So this one would definitely no LVOT obstruction or SAM. So this is very consistent with hypertensive cardiomyopathy. In contrast, this patient also with a concentric pattern, but we see here that there is systolic anterior motion of the mitral valve leaflet to LVOT obstruction. So this would be an example of hypertrophic cardiomyopathy. So this is another example. So if we look at this, so what's going on here? Is this hypertrophic cardiomyopathy? Is this hypertensive cardiomyopathy? Or is this something else? So sometimes the delayed enhancement can help a lot. So when we did the delayed enhancement in this patient, we see here like this diffuse enhancement involving all the walls, very patchy, and this is very typical for cardiac amyloidosis. Another example here of amyloidosis, again, concentric pattern of hypertrophy and this diffuse pattern of delayed enhancement. And just to show the difference, so for those that are not used with delayed enhancement image, so this is an example of a normal patient. So the normal heart would look like this, a homogeneously black left ventricular myocardium. This is ischemic heart disease. You can see here this area of scar here in the LAD territory. So this is a chronic LAD infarct. And then this is hypertrophic cardiomyopathy with patchy hyperenhancement involving here this really thick septum. And just by comparison, we can see here amyloid. We can see that they are very different. So after we're used to this kind of images, most of the time it's not too difficult to differentiate one from the other. But there are overlapping cases that can be tough. So another differential, Fabry disease, we can see that in terms of phenotypic presentation can be very similar, significant hypertrophy in a concentric pattern, but also involving more pronouncedly, more prominently the septum. And we can see a little bit of a delayed enhancement here in the infralateral wall, which is typical for Fabry disease. And in those patients, I think it's important to consider the diagnosis, especially if the patient also has a neurological or skin disorders, sometimes kidney involvement as well. So that would point towards the possibility of Fabry disease. So Friedreich ataxia, so it's another differential, can present very similarly, again, with the thickening of the septum here. And again, in this patient, not a lot of delayed enhancement in this case. And again, I think we'll have to have into to the clinical picture. So if there's also neurological symptoms, I think it helps, but as many as 85% of these patients can present with significant hypertrophy. But if they have neurological changes or diabetes, which is not unusual in these patients, then I think it's reasonable to look for this diagnosis. Unusual cases also, and something that it's not often seen as presenting as HCM, this is an example of hypereosinophilic syndrome. So this patient has this area of hypertrophy here involving the anterolateral wall. So we thought, what's going on here? And then when we did additional sequences, we saw that there is some degree of edema in this region and delayed enhancement. So some degree of acute necrosis here, and the patient was found also to have significant elevation in troponins. So this was more like an acute case of myocarditis in a patient with hypereosinophilic syndrome. But if we looked only at Ancinis and the echo similarly would show something like this, we would see this asymmetric hypertrophy involving the anterolateral wall. And finally, I think this is the final differential I'll show. It's Denon's disease. Again, can present very similarly to hypertrophic cardiomyopathy. It's caused by abnormal LAMP2 gene. And then we can see here that these patients also have significant hyperenhancement here involving the septum, but also the lateral wall. And these patients tend to present at a young age. So we have to be pay attention to this and take into consideration this possibility in these patients. So about risk stratification, so how can MRI help with that? I think this is an important feature. And it's very important, I think, to look and stratify the risk for sudden cardiac death, because as we can see, it is the hypertrophic cardiomyopathy is the most common cause of sudden death in young competitive athletes. So as many as 35%, and this is possible HCM, so more than 40% if we include both, are caused by hypertrophic cardiomyopathy. And also another reason for us, another fact that shows the importance of checking risk stratifying these patients is when we look at the mortality of these patients. So this early HCM cohorts that was more like referral cohorts, so selected patients with more advanced disease, they had a higher likelihood of having adverse events. So when we look at more recent cohorts, but prior to the utilization of the current treatment strategies, we can still see a higher rate of events, higher risk of sudden cardiac death. But more recently, when we look at patients that have hypertrophic cardiomyopathy but have underwent, for example, ICD implantation, heart transplantation, myectomy, all the therapies that we have available now, then they show a rate of event that is similar to the general US population. So by identifying these patients and properly addressing the issues at hand, then we can change the prognosis of the patient and bring them to the same prognostic situation as the general population. So, and how can we do that? One of the main factors that we can use in MRI is the delayed enhancement and try to quantify how much fibrosis these patients have. So these are all examples, different examples of patients with hypertrophic cardiomyopathy, and we can see that it can range from no delayed enhancement at all. Some of these patients have no delayed enhancement, and then progressively we can see here patients with more and more delayed enhancement, sometimes having very diffuse and extensive delayed enhancement involving most walls. And this has been shown to correlate with the chances of having sudden cardiac death. So in this landmark study here, they assessed almost 1,300 patients, and they showed that actually the presence of delayed enhancement, especially if it was more than 15% of the LV mass was enhanced, then the chances of having sudden cardiac death increased significantly, doubled if it was more than 15%. And then a meta-analysis using that study and others showing here that the higher the percentage of hyperenhancement, the higher the chance that the patient would have a sudden cardiac death or an adverse event. So the presence and extent of delayed enhancement is a strong prognostic factors, and as you will see in the most recent guidelines, they integrated that in terms of how to risk stratify these patients. But not only delayed enhancement, also the presence, as I mentioned before, the presence of an apical aneurysm. So we can see here an apical aneurysm, and in this study, they showed that when patients have this, they have a higher chance of having sudden cardiac death also, ventricular arrhythmias, ICD firings, and also a higher chance of thromboembolic events because of this aneurysm. So in the end, they end up having more events. So it's another important prognostic factor. And this is a study, again, done here by Dr. Harris, Dr. Lesser, and colleagues. And what they showed here is that end-stage HCM, it's also a significant prognostic factor. The prevalence, they estimated at 3.5%, 3.5% of patients. And what they showed is that these patients that had end-stage HCM characterized by LV dysfunction, they were diagnosed at an earlier age as compared to the ones without end-stage disease, had more severe symptoms, larger LV cavities, thicker septum, and less frequent outflow gradients of 30 millimeters at rest. And as I mentioned, they found that this was an unfavorable complication with the higher rates of mortality and also eventually going into heart failure, atrial fibrillation, and so on. So here's an example of a patient with an end-stage hypertrophic cardiomyopathy. We can see here the CINI showing significant left ventricular dysfunction. And this is a patient, a 23-year-old patient, and look at the amount of fibrosis that the patient has. Significant, extensive fibrosis involving almost all left ventricular walls. So a very significant case. And again, this is an important prognostic factor. And as I mentioned, so the most recent guidelines for management of hypertrophic cardiomyopathy, they list here the factors that we should take into consideration when assess the risk of these patients. And at least 3 of them, I think MRI can contribute in terms of providing useful information. So for example, the presence of left ventricular systolic dysfunction, an EF of less than 50%. In those cases, for example, the end-stage disease, I think this it's an important prognostic factor. As I mentioned, the presence of LV apical aneurysm, it's also an important factor, and the presence of extensive delayed enhancement or on CMR, especially if it's more than 15%. So in terms of future perspectives, I think one of the main things that are under discussion nowadays, it concerns the very diagnosis of the disease. So it discusses and questions the diagnostic criteria. So the fact that the disease definition is based on a binary decision between using 15 millimeters of maximal wall thickness as the main criteria, I think this has been an issue. And one of the reasons is that even the way we measure this maximal wall thickness can vary a lot from modality to modality, so comparing MRI with echo, or even within the same modality if different observers measure. So will they include like the crista supraventricularis or not, or dysreticulation, where they will measure, what kind of image they will use to measure the maximal wall thickness. So there's a high measurement variability. And this can affect significantly the diagnosis and also prognosis of this patient. So I think in the future, we will see more and more, we'll try to move towards to standardize more how we do this and try to make it more consistent and robust in terms of being reproducible, the way we measure this over different modalities and different observers. And also to exemplify this issue, I think there's some interesting recent studies showing this situation, which is not unusual that we will see this in clinical practice. We just recently saw a case, I remember discussing this with João. These are patients that actually they do not meet criteria for hypertrophic cardiomyopathy. In other words, the maximal wall thickness is not 15 millimeters or more, but they have this relative hypertrophy of the apex. So we can see in the normal heart, we would expect the basal segments to be thicker than the apex. So it tends to become, the wall thickness tends to become thinner as it reaches the apex. And this patient present with the opposite, this relative hypertrophy of the apex as compared to the base. And then, and also they frequently present with this abnormal T-wave inversions that are typical for patients with apical hypertrophic cardiomyopathy. And we see this more and more, and now we are trying to describe this as a possible early phenotype or mild phenotype for HCM. And it's not unusual that a situation like this will occur. So we see that these patients have this relative hypertrophy, but not meeting criteria. But then when we image year later, then they eventually develop the full phenotype of the disease. So I think with also serial imaging, follow-up imaging of these patients can be helpful. So this is one example of a study addressing this, and this is another one published more recently showing the same thing, this relative hypertrophy of the apex, also associated with this abnormal T-wave inversion. So if you see something like this on the ECG, I think one of the things you have to consider is the possibility of this maybe mild phenotype of apical HCM. Regarding risk stratification, so we discussed the ones that are being used nowadays. But also, I think there is some data showing that the progression of hypertrophy, in other words, the worsening or increasing of the degree of fibrosis over time in patients with hypertrophic cardiomyopathy is also a marker of worse prognosis. So when the patient, I think this is intuitive, but it's important to show with the data. And this study showed that when there is LGE, delayed enhancement progression over time, these patients tend to have more ICD, require more ICD implantation, more progression to end-stage HCMs, and more admission for heart failure. So it's a marker of worse prognosis as well. And as I mentioned, small vessel ischemia, we can see that with MRI. This is another example showing that same pattern with diffuse ischemia, circumferential ischemia involving almost all LV walls. In this case, affecting more like mid to the apical segments. And then there is some data, this paper from almost 20 years ago in New England showing that the presence of microvascular dysfunction, it is associated with worse prognosis in hypertrophic cardiomyopathy patients. So if the myocardial blood flow reserve is decreased in these patients, they have a higher chance of having events. And more recently, this study here showing small vessel ischemia by MRI, and when they had the presence of this finding, they would have more non-sustained VT on a Holter. They would more frequently have the presence of apical aneurysm and also have higher left ventricular mass. So as I said, I personally believe that this is a precursor for patients developing more and more fibrosis. And I think if we find a way to systematically image this well, I think it could be helpful for prognosis. And I'll just mention, I didn't mention before, I believe this is very helpful for diagnosis as well. Some patients, when we try to differentiate between hypertrophic cardiomyopathy and hypertensive cardiomyopathy, for instances, or the differentials, one of the things that are very useful is that if we stress the patient and we see this pattern of circumferential hypoperfusion, I think it favors significantly the diagnosis of hypertrophic cardiomyopathy, because this is a very typical feature. So I think it's helpful not only for prognosis, but for diagnosis as well. And getting towards the end now, but another perspective now, it has to do with this newer therapy options that we have now, the myosin inhibitors, so mavacamten, as in this example here. I think this is really changing how we manage these patients, and I think it will really, it's already changed a lot, and it will change more and more how we'll manage these patients. And I think this is some initial studies using MRI and showing that actually when you use these medications, we cause what we could define as reverse remodeling. So these patients, when they use this myosin inhibitor medication for a few months, it showed that actually it decreased left ventricular mass index significantly. It also decreased the left ventricular wall, maximal wall thickness when compared to placebo, and also left atrial sizes. So these medications can really help reverse even the morphology of the disease towards what would be considered normal. And more recently, we have this same kind of study, but using now a newer drug, aficamten. I don't know if I'm pronouncing this right, but I took a guess here, aficamten as the medication. And then it showed basically the same pattern as the other one. So when patients used this medication, it showed that there was a significant decrease in left ventricular, left atrial volume, also decreased significantly the LVOT gradients, both at rest and with provocation, and it decreased left ventricular mass index and maximal wall thickness. So with MRI, we can show this reverse remodeling. We can show response to therapy. And it's very interesting to think, we were discussing this, whether these patients, even after stopping the medication, whether this would be changes that would be more permanent, or it would still linger even after stopping the medication. So this is something that I think MRI can help solve. And also, I think it's a very interesting area to address is also if we can use MRI to try also to select the patients that will most likely respond to this kind of therapy. So are there features on MRI like wall thickness, the amount of fibrosis that the patient has, the presence of small vessel ischemia? So are those features that we can use in terms of characterization using MRI? Can we use that to select the patients that will benefit most from this kind of new therapy? So I think this is very promising. So to summarize, I think MRI can, nowadays, I think it's a modality that it should be used, if not in most patients with HCM, if not all patients with suspected or known HCM, because it provides a lot of complementary information to echocardiography in terms not only of diagnosis, but also phenotypic expressions, including assessing maximal wall thickness, distribution of LVH, the presence of apical aneurysms, extent of delayed enhancement, small vessel ischemia, all those features that I mentioned that can help not only with diagnosis, but also do with risk stratification, and possibly with these newer therapies also helping with management decisions regarding which patients will benefit most from this novel therapies. Thank you very much.
Outstanding. That was a wonderful and very updated review. I appreciate you bringing so many insights. Any questions from the audience? For Nick?
I'm wondering if there's any data on the effect of mavacamten on small vessel ischemia.
Not that I know of. it's possible that there is, but as far as at least those two studies that are reviewed, they did not address small vessel ischemia, at least not so far, but I think it would be a very interesting topic, I think, for future research.
So along those lines, when we are, facing a potential questionable diagnosis of HCM and we consider the MRI, should we request the MRI with stress as well, with perfusion? Because, if that is another phenotypic expression of it, could you also leverage that diagnosis and increase the sensitivity to specificity then?
I think so. I think it depends a little bit on what you're looking with the study. But let's say you have a patient with suspected HCM, and then you're trying to make the diagnosis. I would do it. I would order with adenosine stress, even if the patient is young. We're not looking for a CAD kind of epicardial CAD. We're looking for a small vessel ischemia. But I would do it. If it's a patient with a known diagnosis, and now we are contemplating, let's say, a septal reduction therapy, and we want to characterize the LVOT area, papillary muscle insertion, all those factors that I think are useful in terms of planning surgery, then for those patients, I don't think we need the stress part because we're looking for different things. But if we're looking for diagnosis or possibly prognosis in the future, then yes, I think I would use the stress.
Scott?
Thank you. That was great, Clerio. As you know, the use of primary prevention ICD in HCM was really pioneered here. And the interesting thing to me is this long latency period that some of these patients have between diagnosis and the actual sudden arrhythmia. And I'm wondering if we have ever looked at the serial MRI changes in these patients that might portend the malignant phase of the HCM.
This is a wonderful question, and I would say that I think we are starting to look at that. One of those studies showing like progression of delayed enhancement and how those patients that have worse progression of in terms of developing more and more fibrosis have a higher risk of events. I think this is like the beginning of this, but I think we should do more in terms of trying to characterize and try to, and also if I think. And this is one of the things that make it difficult. For example, let's say we do an MRI on a patient for diagnosis or prognosis purposes, and then we see an amount of delayed enhancement of 18%, which would be like a significant risk factor. But I personally think that it's completely different if we do that and it's a 15-year-old patient as opposed to a 70-year-old patient. So I don't think it's only a matter of how much fibrosis you have, but you have to put that into context and then integrate that with all the rest, all the information. And I think if we do that in a more effective way, I think it will give even a more powerful information in terms of stratification. So, but I agree, we have to look into the spectrum of the disease.
Well, to your point, then, since many of these patients are younger, then should serial MRIs be a part of the process? Is there any guidelines along that way?
And in what frequency as well should we image them?
Yeah, I don't think it's established at this point. I think they suggest that if you are concerned with any feature that the progression, I think they, even on the guidelines, I think they suggest like a 2B kind of indication for this kind of serial assessment if you're looking for a specific feature. But I think there's no recommendations at this point to do like serial imaging for all or at least some in specific situation. I think it's still open to clinical judgment, but I think as we try to research this more, I think we should come up with for which patients and what frequency and try to get more guidelines in terms of how to follow this patient. But at this point, I don't think there are any rules.
David? And then we'll go to John.
Hey, Clerio, that's a great talk. Kind of in a similar context, I mean, the conventional thinking is that vast majority of patients with HCM has normal prognosis and their longevity is similar to the general population. So with that, how do you decide how frequently do you want to test these patients, image these patients, and how do you use your resources if vast majority of patients has good prognosis?
I think I'll tell you, as I said, I think there are no clear recommendations at this point. I'll tell you my rationale and what I personally would do. So I think if we're, and it has to do a lot of the stage that the patient is in. If we're talking about a young patient, I would image and try to characterize as much as possible at a baseline to get the amount of hypertrophy, the maximum wall thickness that the patient has, if there's obstruction or not, the amount of fibrosis that the patient has, if there's apical aneurysm, and all those things that we discussed. So I would get that at baseline. And then if it's a young patient, I would image from time to time using echocardiography. And they recommend doing that anyway, with echo at least, I think every 1 or 2 years, if I'm not mistaken. So I would do that, but from time to time, instead of using an echo, I would repeat the MRI. If we're talking about younger patients, so I'm sorry, so if we're talking about younger patients, I would follow these patients and then I would image with MRI from time to time to get newer information or updated information about the amount of fibrosis, looking at for aneurysms with more detail because sometimes the echo may miss, and so on. So what frequency? Maybe every 5 years or so, or 5, 6 years, but again, I'm just guessing. If we're talking about older patients, so it's a 60-year-old patient, 70-year-old patient, so I would get a baseline, but depending on what I see, I don't feel that I would need to repeat it unless there is significant change in his clinical situation. So if the patient is clinically stable, I don't think we need to keep repeating it. If we're talking about an older patient without a lot of risk factors, I think we can assess him initially and then follow with echo and then looking at the clinical picture. But that's my take, but I think we should come up with more established guidelines on how to do that.
John, there's a question online?
Yes, we have 2 virtual questions thus far, so thank you very much for your time this morning. The first question comes from Dr. Timothy Dirks. And the question is, what is the correlation between degree of a hypertrophy and extent of fibrosis?
Yes, so again, there is, so patients with more hypertrophy tends to have more fibrosis. I don't know exactly the exact correlation factor, but the higher the maximal wall thickness or the degree of hypertrophy that the patient has, the more fibrosis or the higher the chances that the patient will have higher fibrosis. So this do exist, but one thing we have to be careful is that sometimes, as we saw in those patients with end-stage disease, what can happen if they have a lot of fibrosis and patients with that eventually evolve into end-stage disease, there's a chance that the fibrosis will actually decrease the wall thickness. So as the patients got thick, even more sick, they will not, the wall thickness will actually tend to decrease because it will become fibrotic, and then he will eventually develop significant left ventricular dysfunction and so on. So there is a correlation between the amount of fibrosis and the maximal wall thickness. But as the disease progresses, this can actually becomes like the other way around. As it becomes even more fibrotic and more disease, the wall thickness will decrease.
Thank you very much for that. We do have a final question from Dr. Kevin Harris, and the question is, first he says, that was a fantastic overview, thanks so much. Can you remind us regarding doing exams with ICD, the considerations and limitations?
Yeah, so I think nowadays, I think we can image really the vast majority of patients with ICD. If it's a non-conditional device, I think we have no issues in most patients. But if it's a conditional device, we have no issues. Even in non-conditional devices, we can image most patients. The limitation, so there's no nowadays there are very few real contraindications for these patients. Even patients with fractured leads and so on, which used to be like absolute contraindications, in some of these patients we can still image them under supervision and so on. So that's not a limitation. The limitation tends to be image quality. So if the ICD sits closer to the heart, then it can lead to artifacts and affect image quality. So this is more common in non-conditional devices. So conditional device tends to have less metal in it, so the artifacts tends to be less. On non-conditional devices, then it depends. In some patients, it's further away from the heart, or the device causes less artifact. It's difficult to tell, but even using a specific MRI pulse sequences specifically designed for that, for most patients, even with non-conditional device, we still can get an image quality that is good enough for diagnosis and for assessing all those features that we mentioned here. So I don't think it should be viewed as a limit. It is a limitation and makes imaging more difficult, but it should not be viewed as a contraindication or a reason for not or to bother the test.
Yeah, if I might just add, the ones that make it harder for us are the subcutaneous ICDs, because they're larger and sometimes they come very close to the LV and the apex. So those typically are harder. Maybe the extravascular ICDs that are coming up now might have a better position and favorable imaging, but intravascular, like Dr. Azevedo mentioned, it should not be a problem. Any last questions? Well, I wanted to say thank you, Clerio. This was a fantastic overview. I'm so glad to have you here.